Let's start with the lecture. So that's where we were yesterday, and this is the question we did yesterday, right? And while other people join, you can have a look at this question once again if you were not there yesterday. And then we will go on to the next question, right? So let's see what your answer is. All right, so I think I will answer it for you. Yes, the correct answer is D, as we discussed yesterday, that we have to increase the daily insulin dose because corticosteroids cause hyperglycemia. And we also said that A and B are the wrong choices because this is type 1 diabetes and these two are the drugs for type 2 diabetes, right? So let's go on to the next question, which is here. All right, that's the previous question written in another way. So I guess it's not difficult to answer this one. All right, that's, I think I'll give the answer for you. I got one answer, which is start a course of amoxicillin clavulanate. Right, so a 14-year-old boy is admitted with spiking fever, chest pain, and respiratory distress. He is diagnosed with pneumonia, and the culture reveals mycoplasma pneumonia. And do you all agree with this treatment? Amoxicillin is a cell wall inhibitor, right? Mycoplasma doesn't have a cell wall, unfortunately. So you will not use amoxicillin. If you have to use an antibiotic, use a macrolide. All right. The answer is A. Include trimethoprim sulfa methoxazole in his treatment regimen. Okay. Which of the following therapeutics in the management of this patient? All right, well, you have to treat pneumonia, that's correct. But in this case, because pneumonia is a stress that the body is under, and in stress, the body releases cortisol, and cortisol is going to cause hyperglycemia, right? So again, the answer, just like the previous question, the answer is increasing the dose of insulin. As far as the treatment of pneumonia is concerned, we can use macrolides or levofloxacin, which is respiratory fluoroquinolone. You can use doxycycline, which is also used for atypical bacteria, right? So the correct answer for this question is B, which is increase the daily dose of insulin. Right, so let's go on to the adverse reaction of insulin. And the first one that you should consider is hypoglycemia. That is, this is the most serious and common adverse reaction to insulin, right? Because most of the patients, if you have seen, they must keep something sweet with them. All right, and as we go ahead, we will discuss this further because, you know, insulin must be given when the patient has a possibility of having hyperglycemia, and that is with meals. All right, so rapid acting insulins are usually given with meals, and obviously if somewhere in between the person has to do some physical exertion which will cause greater utilization of glucose in the body, he can go into hypoglycemia. That is why most of the times, patient, for example, for some reason, they are traveling or something, they don't get a meal. So there is a possibility of going into hypoglycemia. So that's why they have to keep something sweet with them all the times. Other adverse reactions include weight gain, local injection site reactions, and lipodystrophy. Decrease insulin dose in renal insufficiency because uh, kidneys play some role in the metabolism of insulin. Um, this is important. Symptoms of hypoglycemia, you must know them: tachycardia, weakness, anxiety, vertigo, sweating, blurred vision, hunger, lightheadedness. And that is the reason, because tachycardia and anxiety both could be treated with beta blockers. So that is why beta blockers should be used with caution in patients who are diabetics. All right. Lipodystrophy can be minimized by rotation of injection sites. There are so many injection sites on the thighs, abdomen, different places that we should rotate, right? And this is an electron micrograph of finger pricks that the patient, this is a finger, right? And the patient has been using drops of blood to measure his preprandial, which means before the meals, glucose levels. So you can see the effects over here, okay? I've got some pictures of lipodystrophy, but I don't think they are in this lecture. They are in another lecture. Anyway, let's look at the duration of various insulins. Exercise caution when adjusting insulin treatment, paying strict attention to dose and type of insulin. So here we are looking at time in hours, and this is the relative insulin effect. So it is a relative effect. It is not an absolute effect or an absolute measure of the effect. So rapid, Lispro, and aspart, they act very fast. And in one of the tables, I will give you the time to onset of action and the duration of action. So this is the rapid acting insulins. And this is regular insulin, which is short acting. Again, pretty close to rapid acting insulins. This is NPH, intermediate acting, not very commonly used these days. This is detemir, which is long acting, and Glargine is even longer acting, right? Both of these are used once daily as basal insulins. All right, elimination. Insulin is removed from the body by enzymes in the kidney and the liver, as well as its interaction with the insulin receptors. So we saw that when the receptor is internalized after insulin binds to the receptor recycles back, but insulin is degraded inside the cells, which means inside the muscle cells or the adipocytes or the liver cells, all right? So that is the major way of eliminating insulin. The glomerular clearance of insulin may occur both by non-specific diffusion and by specific receptor-mediated transport, but most of the insulin that is filtered into the nephrons is reabsorbed, okay? After entering the tubule lumen, more than 99% of the insulin is reabsorbed by proximal tubule, primarily by endocytosis. And relatively little insulin is ultimately excreted in urine. So if you have to measure insulin level, you have to measure that in the blood. And of course, you have to measure the C-peptide levels as well to see whether it is endogenous insulin or exogenous. Right, so let's go on to the insulins now. We will first look at rapid and short-acting insulin preparations. We have got 4 insulin preparations. Regular insulin is short-acting, but Lispro, aspart, and glulisine, they are rapid-acting, all right? Regular insulin, here it is known as Humulin. It is also recombinant. And regular insulin is structurally identical to human insulin. It contains glycerin, crystalline zinc, and water. You know that these are the stabilizers, and they sometimes also they also alter the charges on the proteins like zinc. You know, zinc is many times added to insulins to increase their duration of action, but that is in combination with protein, and protamine. We'll come to that in a couple of slides later. Other insulin preparations are produced by modification of regular insulins. We have already seen that. This is also injected subcutaneously, although it is not written, but this is the only insulin that we can use intravenously as well, particularly in emergencies like diabetic ketoacidosis or in hyperosmolar non-ketotic coma, or it is also used in patients who are diabetic and who are admitted to the hospital with serious infections or any other serious diseases. As I showed you in that question, that could lead to secretion of cortisol and higher glucose levels in the blood. So this is Lispro. Lispro differs from regular, that proline and lysine at position 28 and 29 have been reversed, that we have seen previously, and I'm showing that to you over here again. So in the beta chain, this proline and lysine, this is the endogenous insulin, has been reversed, and that is why we call it Lispro, lysine and proline, okay? This modification results in more rapid absorption, a quicker onset and short duration of action after subcutaneous injection. So when you give subcutaneous injection, it depends whether these insulin molecules can clump together or not, all right? And that depends upon various factors. It depends upon the addition of excipients like strong ionic compounds that will not allow insulin to clump together. And it also depends upon the isoelectric point of that in particular insulin. I will come to isoelectric point a little bit later when we discuss Glargine. So the absorption basically depends upon the formation of hexamers, like Jamal said yesterday, when you inject that in the subcutaneous tissue. Right. Peak levels of insulin Lispro are seen 30 to 90 minutes as compared to 50 to 120 minutes of regular insulin. So important point to remember. And also remember that this is taken about 15 to 20 minutes before meals. The literature always writes 15 minutes before meals. And we are getting pre-filled pens these days, which can adjust the dose. So you have got this marking over here of the units, how many units of insulin you have to enter. So this is, you can calculate that if you want, or otherwise if you're using fixed combinations, that is a different thing, okay? So this is a newer drug, and it could be given intravenously. Like I mentioned yesterday, previously we had only regular insulin that could be given intravenously. Now we have got one or two more preparations, and they are both rapidly acting insulins, right? This is known as Lumjev. It was approved in June 2020, and it was achieved in Japan, Europe, everywhere, all right? And you see this one point I want to bring to your attention, that it says Insulin Lispro AABC. Anybody knows what this AABC? You'll see these four letters in lowercase, four lowercase letters in many drugs. Anyone knows what these are? Because many students, they don't know, and they ask that, what is this? You know, it doesn't make any sense. Yes, it doesn't make any sense. You know, it is not there to make any sense. It only shows that this is a biosimilar, okay? The instructions by FDA are that biosimilar could be given any four alphabets in lowercase, in any combination.
I don't have it.
They do not necessarily mean anything, all right? Let me mute everyone. There is some background noise. Okay, so that was all about biosimilars. Biosimilars are any drugs which are very similar to the original drug. They are prepared by some other pharmaceutical company, and they have the same mechanism of action. They have the same rate of absorption. They have the same efficacy. They have the same side effects. The only difference between biosimilars could possibly be in the excipients, all right? So, and we are getting a lot of biosimilars these days, and whenever you see these 4 alphabets, you should understand that it is a biosimilar, okay? We are getting biosimilars in monoclonal antibodies as well. Okay. No, bioequivalence is something else. Bioequivalence is different from biosimilars. Bioequivalence means that 2 drugs in different doses have the same effect, right? But for example, you can take these painkillers, NSAIDs, you know, some are more potent than the other. Bioequivalence would mean they will have the same efficacy at a certain dose, okay? So that is what bioequivalence is. Biosimilar is something different. All right. We have got another preparation, which is, we will come to mixed drugs as well, but you see that insulin lispro protamine is there. And if you remember protamine, we have done protamine before as well. And do you remember that protamine sulfate is an antidote for heparin? It is a positively charged molecule. So what does it do in with insulin? And it turns out that when we add protamine to insulin, it increases the, it slows down the absorption because it helps in the formation of hexamers in the subcutaneous space, okay? So protamine is obtained from salmon sperm. These days we are getting a recombinant form of protamine. So this is a mixture of short acting. Obviously, Lispro, this insulin Lispro is short acting and protamine is longer acting. And you give it twice daily, 50% in insulin Lispro protamine, which is intermediate acting, and Lispro injection rapid acting, right? So you give it 15 minutes before meals as usual. You give it twice daily, just like in the combination of NPH and regular insulin. We'll come to that a little bit later. You have, but remember that whenever you are giving insulin to the patients, you have to individualize the dose, okay? It depends upon a lot of things, you know, but the thing is that the patient must calculate his carbohydrate intake. That is one thing. The carbohydrates, same amount should be taken at the same time of the day, right? With every meal, you have to calculate that. And the second thing is that the physical activity, same amount of physical activity at the same time every day. After that, after these instructions, then you decide how much insulin to give. And I've written the dose somewhere over here. Yes, here it is. Total daily insulin requirement are estimated to be between 0.5 and 1 unit of kilogram per day. Now, you know, per kilogram per day, which means if it is a 70 kilogram man, he will get 35 to 70 units of insulin per day. Now, how much of that insulin has to be rapid acting or short acting, and how much of that insulin has to be basal insulin? Now that again depends, but 50% or more than 50% has to be basal insulin, right? Some doctors decide more than that, but as I said, it has to be individualized, all right? Okay, 50%, Jamal says 50%, but you know, different guidelines have got differences in them. But anyway, we will agree to that 50% for that moment. And keep in mind that it has to be individualized. And we have got this dial a dose insulin pen. You can adjust the dose if you are on a sliding scale, which is no longer used, but sometimes you still have to calculate or adjust the dose of insulin. So by the twist of this knob over here, you can adjust the dose, whatever number of units you want to take, all right? So insulin aspart and glulisine, they are also rapid acting. Pharmacokinetic and pharmacodynamic properties are similar to Lispro. And here is Novolog, which is aspart. This is the primary structure on beta chain. Number 28 amino acid proline has been substituted with aspartic acid, okay, or aspartate. Again, we are getting pre-filled pens for all types of insulins, and not only insulins, many other drugs as well. So rapid or short-acting insulins are administered to mimic prandial mean time release of insulin. So, what we are trying to do is in treating the patients, although we can never reproduce the action of the pancreas works on minute to minute or even second to second basis. The coordination between the beta cells of the pancreas and the GI hormones like incretins, uh, we can never reproduce that. That is the natural system. But we want to be as close as possible. That is why we are giving insulin, short-acting insulins before the meals or soon after the meals. It's better to give before the meals. And we are trying to calculate all these physical activity and carbohydrate intake. And we are giving a basal insulin as well. So that is what our objective is. And how do we achieve that? We achieve that by keeping hemoglobin A1C below 7%, although it is about 154 milligram per deciliter of glucose in the blood, okay? So that is our target actually when we treat diabetes. So again, this is Epidra, and this is glulisine. It is used subcutaneously. They may also be used in cases where swift correction of elevated glucose is needed. Rapid and short-acting insulins are usually used in conjunction with a long-acting basal insulin. We already know that. Rapid-acting insulins are administered in 15 minutes, in the 15 minutes preceding or within 15 to 20 minutes after starting a meal. It's always to take it before, but if a patient takes it before a meal and he delays taking the meal, that could be a problem. That could lead to hypoglycemia. So we must make sure that the meal is taken within 15 minutes of taking insulin. Rapid-acting insulins are commonly used in external insulin pumps. We saw that the insulin pumps have got both type of insulins, especially if the pump is there with a sensor that is on the skin. The sensor is measuring the glucose level all the time. So the pump is providing basal insulin as well as rapid-acting insulin whenever needed, okay? So this is another development. This is quite old now. FDA approves fast-acting insulin aspart. With the approval, dosing can begin at the beginning of meal or within 20 minutes of consumption of meal. The drug's unique formula consists of 2 added excipients, right? Now, because, we can give this intravenously as well. And if you add an excipient that is going to cause crystallization or formation of hexamer of insulin, you cannot give that intravenously because that is meant to be given subcutaneously and slow down the absorption. Just like you have got this benzathine penicillin. Benzathine penicillin is basically meant for intramuscular injection because it delays, it slows down the absorption of penicillin, and it's given once in monthly. You can't give that intravenously. That's going to defeat the whole purpose, okay? So this is, these are the 2 excipients that have been added, and this is known as FIASP. It is aspart, and you can see that it is given intravenously for subcutaneous or intravenous use. And here it is, it says, so now we have got 3 subcutaneous, right? We have got regular insulin, we have got this aspart, and we have got this Lispro, okay? They can be given intravenously. Right, so let's see what this question is. What is the effect of insulin on lipid metabolism? Okay. All right, I got one answer, which is D. It says decreased synthesis of lipoprotein lipase. Actually, insulin increases the activity of lipoprotein lipase because lipoprotein lipase extracts triglycerides from VLDL particles and moves them into the adipocytes, right? So it does not decrease the synthesis. If anything, it is going to increase the synthesis and activity of lipoprotein lipase. Increased activity of hormone sensitive lipase. Actually, insulin decreases the sensitivity of hormone sensitive lipase because the insulin, also converts glucose to triglycerides, right? So triglycerides cannot be converted to glucose. I don't think there is any mechanism in the body, but these glucose can be converted to triglycerides, and and insulin is actually preventing the release of triglycerides. Very good. So the correct answer is actually C, that someone gave over there. It increases triglyceride synthesis inside the cells and also in the liver, all right? So the correct answer is C. Insulin increases synthesis of triglycerides both in liver and adipose tissue. In adipose tissue, it promotes breakdown. See, this is what I was trying to tell you. It promotes breakdown of glucose to alpha glycerol phosphate that is used in the synthesis of triglycerides, right? That is one thing you should keep in mind, all right? Now we go on to intermediate acting insulin, which is neutral protamine hagedon. It is an intermediate acting insulin formation formed by the action of zinc and protamine to regular insulin, right? So protamine, as I said, it will promote the formation of hexamers, slow down the release, and zinc has got a charge. This is also going to stabilize the hexamer crystals that are formed. But, the problem with hagedon is that the crystals are different in sizes when you inject it in subcutaneous tissue, and the release of insulin from there is not very smooth, all right? So it is not very commonly used by the physicians. These days what I am seeing is that most of the physicians, they are using Degludec. Okay, although Glargine is also very common, but somehow Degludec is becoming more common. Another name for this preparation is insulin isophane. And here it is. The route of administration is subcutaneous. Mechanism of delayed absorption: the combination of protamine forms a complex that is less soluble, resulting in delayed absorption and longer duration of action. It is used twice daily in basal control in type 1 or type 2 diabetes. And of course, it comes in different combinations. The most common combination is with regular insulin, which is used twice daily. We don't use it when rapid glucose lowering is required. For example, in ketoacidosis, the most common insulin that is used over there is regular insulin. And obviously, we don't have to give IV because it has been prepared to form those hexamer crystals and for subcutaneous injection. Right, so now we go on to long-acting insulin preparations. Again, they are given subcutaneously. This is Lantus, which is another well-known name for Glargine. No, the isoelectric point of insulin Glargine is lower than human insulin, leading to formation of precipitate at the injection site. Now, the thing, what is isoelectric point? I mentioned this previously as well. Isoelectric point is the pH at which the protein has got no charge. All right. So different proteins have got both positively charged amino acids and negatively charged amino acids. So they have different charges, their overall charge, whatever it is, okay? So this normal pH in the body is about 7.4, let us say, okay? And the isoelectric point of the natural insulin is at pH 5.4, which is acidic pH. But the pH of Glargine is about 6.7. I mean, the isoelectric point is 6.7, right? Which means it is closer to our natural pH or normal pH in the body, in the plasma, okay, extracellular fluid. Now, the thing is that when it has got no charge, if it has got a charge, all the particles have the same charge. Let us say all the protein particles have got a positive charge. They will repel each other. If all of them have got a negative charge, again, they will repel each other, right? But when they have got no charge, they clump together and they form these crystals or hexamers, okay? So that is why this isoelectric point is also important to understand. And but that is not the only thing that counts, because you will see that the isoelectric point of insulin Degludec, which is also a long-acting insulin, is actually 5.4, okay? But that is prepared in a neutral pH, and it also has got strong ionic components in the preparations. Anyway, so this is, and you remember that we added two arginines to Glargine, okay? We added one glycine and two arginines. That is why we call it Glargine. So these two, addition of these two Glargines have changed the isoelectric point of Glargine, and that is why it is long-acting. It has slower onset than NPH insulin and a flat, prolonged hypoglycemic effect with no peak. Long-acting insulins should not be mixed in the same syringe with other insulins, because doing so may alter the pharmacodynamic profile. All right, that's an important point. And we have got this newer preparation. See, this is 100 units. Now we are getting a much stronger one, which is 300 units, and that is also used. Now this comes under aggressive glucose control. Trujillo, I'm coming to this. Yes, thank you very much. I'm coming to this one, Jamal. So 300 units for more aggressive control of diabetes. Here it is. And it is for subcutaneous use only. Contains 3 times as much insulin per ml as standard insulin. Not for use to treat diabetic ketoacidosis. Obviously, remember diabetic ketoacidosis, IV insulin, and should not be used in children as well. Heart failure can occur if Glargine 300 is taken with thiazolidinediones, okay, pioglitazone and rosiglitazone, even if the patient never had heart failure or other problems. So that is one caution that you must remind yourself of. And the benefit of all these long-acting insulins, because they are released slowly, is that there is a lower risk of hypoglycemia. Now we go on to detemir. Now detemir is different. The preparation of detemir is quite different, right? It binds to albumin. Mohammed Jamal says that from which age to Geo can start. Well, I cannot tell you the exact age, but I would say that we include pediatric patients up to the age of 15, 16 years. So let's say, to be on the safe side, we can say 18 years, which is the normal adult age, okay? But honestly speaking, I'm not 100% sure what age to start it at, okay? Right. And the thing is that if you're going to start it for type 2 diabetes, that is a disease of adults. And if you're going to start it for type 1 diabetes, that is a disease of children and adolescents. So in type 1 at the start, at least this cannot be used, this 300 milligram to GO, okay? And type 2, it could be used because that is already a disease of the adults. Okay. So detemir has a fatty acid side chain that enhances association to albumin. And that is the reason for its prolonged duration of action. This is the fatty acid side chain. You see 4 carbon molecules over here. And mechanism of action, slow dissociation from albumin results in long-acting properties similar to those, the longer acting property or the duration is similar to that of Glargine. its duration is actually a few hours shorter than Glargine, okay? And the indication is to maintain the basal level. It is given subcutaneously as is written over here. And these days we are getting cartridges, we are getting these insulin pens or this dial a dose pens, and we have got cartridges for all the different types of insulins that could be fitted in these pens, okay? Right. So which of the following effects does insulin have on the liver? Right. This is an interesting question, right? So when you get a table like this, don't get confused, just pick up one column and start eliminating from here. All right. For example, let us look at this gluconeogenesis, although I can take glycolysis up as well. But gluconeogenesis, we know that insulin suppresses gluconeogenesis. Gluconeogenesis increases the effect of, increases hyperglycemia, right? So there is just one that is suppressing gluconeogenesis. And insulin suppresses glycogenolysis as well, because glycogenolysis also causes hyperglycemia. All right. So the correct answer is B. Yes, that is very good. And glycolysis, why should insulin increase glycolysis? Because glycolysis means metabolism of glucose. Glucose is being broken down by glycolysis, and that is one of the ways to utilize and reduce the level of glucose in the blood. So the correct answer is B. Insulin decreases gluconeogenesis and glycogenolysis and increases glycolysis in the liver. So the correct answer is B. Now we go on to Degludec. This is an ultra long-acting basal insulin, and again modification, addition of, I do not know the exact structure, but again, one amino acid has been changed, perhaps in beta chain, and a side chain has been added in Degludec, okay? And here is Degludec, the brand name. With the brand name, it comes as a pre-filled syringe. Long chain, I'm not sure. What do you mean by long chain of hexamer? Mohammed Jamal has written long chain of hexamer. Hexamer is something that is formed after you inject insulin in the subcutaneous space, okay? And there are lots of ions present in subcutaneous space as well. Yes, there is a long chain that has been added to Degludec. All right. Hexamer means anything that has got 6 parts in it. Hexa is 6, okay? That forms a crystal. So I'll let you know, it just slipped my mind. We do not have to know the exact structure, but some long chain has been added to one of the insulin chains, and one amino acid has been replaced somewhere. Okay, but the important point over here is that it has got a very long duration of action, up to 42 hours, as compared to 18 and 26 hours of detemir is 18, and Glargine is about 24 to 26 hours, okay? Again, subcutaneous injection once daily, maximum dose is 80 units. It provides basal insulin level, and as I said, yes, B29 of human insulin, so beta chain number 29 has been deleted. So not substituted, deleted and conjugated to a side chain. So at this point, a side chain has been added. All right, now what exactly that side chain is, I do not know. But obviously addition of that side chain. Now again, as I said, that the isoelectric point of this Degludec is just like the isoelectric point of regular insulin. So it should be absorbed very rapidly, but it is not, because the excipients that have been added to this, there are two things. Number one, it is supplied at a neutral pH. The preparation is at a neutral pH. And number two, the excipients are highly ionic. Okay, strong ions have been added. So that is why it forms those crystals and it is absorbed slowly. And obviously when it is absorbed slowly, there is a low risk of hypoglycemia. and it is produced by Novo Nordisk, which is pharmaceutical from Netherlands, I guess, and it is approved by FDA as well. And we are getting a combination again with aspart over here. And I'm really not sure how commonly it is used. So 70% Degludec and 30% aspart. And again, we are getting pre-filled syringes for this as well. Now we go on to combinations. We previously saw this Lispro protamine and Lispro short acting. Here is another combination of aspart protamine and normal aspart, 70% by 30%. And obviously this is also given twice daily before meals. This is subcutaneous use and suspension for injections. So that's all we want to know. Use of pre-mixed combinations decreases the number of daily injections, but makes it more difficult to adjust individual components of insulin regimen. Now, you see, this maintaining or adjusting the individual components, which is usually done by taking short-acting insulin separately and long-acting separately, right? Now, that is no longer done. You know, the physicians do not have the time to make a table. Previously, we used to make a table for the patients for the sliding scale. We don't use that any longer. So it is convenient for the patients as well. Still, you know, some patients, they are daily checking their blood glucose levels before the meals or maybe after the meals as well, and taking short-acting insulin, but it is inconvenient, right? So the thing is that it has got drawbacks. You know, it doesn't control the blood glucose level as consistently as you would like it to be, but on the other hand, it is more convenient, right? So so it says 70%, Mohammed Jamal has written 70% basal and 30% insulin bolus. That is why it is, you know, you can take it twice daily only. So that is why it will not have that fine control that we can have with taking insulin separately. But, you know, then the patients forget their daily life is affected. Activities of daily life are affected, and you know, sometimes they miss the doses. So dosage regimen of Humalog will vary among patients and should be determined by the healthcare provider familiar with patients. You see, patients' metabolic needs, body weight, his diet, his physical activity, eating habits, lifestyle variables, okay? So there are a lot of things that you have to take into account, and you have to instruct the patient to strictly adhere, which is the difficult part. You know, the patients do not follow the instructions all the time, and it is difficult on daily basis to follow the instructions. All right. So these are from Lippincott. You know, this is a combination of NPH and regular insulin, twice daily NPH and 3 times with meals. But remember, meals have to be taken at the same time of the day, same amount of carbs, same amount of physical activity at the same time of the day. And this is pre-mixed NPH regular 70/30, which is taken twice daily. And which one? This is isophane injection and regular 70/30, same thing, okay? 70/30 over here. And this is Lispro with a basal Glargine. So what we are trying to do is we are trying to mimic the natural rhythm or the natural levels of insulin after the intake of carbohydrates. And here are the different preparations that we have already seen. And we'll have a look at standard versus intensive treatments. Both have got benefits and both have got harmful effects or disadvantages as well. So standard therapy is twice daily insulin injections, intensive therapies, 3 or more injections daily with frequent blood glucose monitoring. Okay, it is frequent. You will come across the term SMBG, self-monitoring of blood glucose, okay? So self-monitoring of blood glucose is very important unless you have that very expensive glucose pump, insulin pump that can even send messages to the hospitals in case you get hypoglycemia, but that's not common even in the advanced countries. Right. So American Diabetes Association recommends a target mean blood glucose level of 154 milligram per deciliter or less, which amounts to hemoglobin A1C of less than or equal to 7%. Okay. And intensive treatment is more likely to achieve this goal. In the long run, with intensive treatment, there are going to be less adverse effect or more delayed adverse effects. The microvascular and macrovascular complications will be slower to appear, not that they will not appear. Okay, but on the other hand, they are more difficult to practice. Intensive treatment is more difficult to administer for the patient. So frequency of hypoglycemic episodes, coma, and seizure is higher with intensive insulin regimen. Patient on intensive therapy shows significant reduction in microvascular complications, which are retinopathy, neuropathy, and nephropathy. Okay. Contraindications for intensive therapy, so these are contraindications, long standing, you have to, if you want to start that at an early stage as soon as diabetes is diagnosed. Okay. Long standing means many of these microvascular or macrovascular changes have already taken place. So if these are present, you should not start that. Advanced stage, those who cannot recognize hypoglycemia. So these are a few contraindications. So what next in diabetes technology? We have got this special replacement cap that shows people with diabetes how much time has passed since their last insulin. Now the problem is, the older people, they forget when they took their last dose. Younger people, we don't know because they don't have to take medicines. It's in the old age that the people have to take drugs for diabetes. They have to take drug for hypertension. They are on 3 or 4 drugs for heart diseases as well, heart failure or joint pains and whatnot. Okay, so they take a lot of drugs and they forget. That is why we have got those pill boxes for them, right? Pill boxes are a good way to remember when to take a drug or whether you have taken it or not. So this cap, it shows when the patient took the last dose and how much did he take. It is known as time insulin. Okay, it will give you the dose and how much time has lapsed since your previous dose and what was your previous dose. Okay, how many units of insulin was it? Or the other thing is these tags, identification tags. A diabetic patient could fall down, go into coma anywhere. So those who are around, they can read these tags. They could be attached to the wrist, and they can call the doctors or the hospital and they can identify the person. All right. And this is a good table. It gives you onset of action, peak hours, duration of action, maximum duration. This is actually more important. And the appearance in the vial. Okay. So most of them are clear except for NPH because it has got protamine and it has got zinc and all those things, right? So this is an important table. I think it's good to memorize this one, at least the first onset and duration column. Okay, so this is good. Right, let's look at this question. And I think after this, we will call it a day. Which of the following insulin combinations would be suitable for long-term therapy? All right, so Jamal says it is D, and someone written as S in the name says C. Let us look at C, Glargine. So you're just taking Glargine, nothing for prandial control, nothing for meals. No, you don't do that. Okay, this is just a basal one. Jamal says that before breakfast, before lunch, and before supper, you take Lispro, 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 and before bedtime, you take Glargine, which is perfect. Okay, that is how you should do if you want to have a fine control. So remember that the basal is taken usually before bedtime. Okay. And the goal of insulin regimens is to provide basal level of insulin over 24 hours and to supply additional mealtime insulin. See what happens at night when you're asleep. Why does the glucose level, there is a possibility of glucose level of going up. Why does that happen? Two reasons. Number one, the circadian rhythm for, let me see, there is a chat. Somoji effect, yes, that is a possibility, but it is more commonly known as Dawn's effect. Okay, Somoji is something a little bit different. The thing is that at night, 4 to 8 p.m., the cortisol level goes up. Okay, yeah, so it is dawn effect. So at dawn, 4 to 8 p.m., the cortisol level goes up. That is the normal rhythm of the cortisol, right? And the second smaller peak is after 2 o'clock or 3 o'clock in the afternoon. That is one reason for hyperglycemia. And that is one of the reasons, why do children with type 1 diabetes, they are often found unconscious early in the morning. They don't wake up from sleep, right? Number one reason, they do not have insulin or the insulin levels are going down. Number two, cortisol level goes up early in the morning, 4 a.m. or whatever. And the third thing is growth hormone. There is a higher secretion of growth hormone especially when the children are asleep. And growth hormone is also a hyperglycemic. We call them counter-regulatory hormones. There is only one hormone that brings down glucose level, and that is insulin. But we have got 4 that take up or that raise or elevate insulin levels. Okay. And yes, so Jamal says it is glucagon, it is growth hormone, and we have already seen that it is cortisol does that. Okay, growth hormone, glucagon, cortisol, and the fourth one is epinephrine. So there are 4 hormones and they are known as counter-regulatory hormones. This can be done by administering rapid-acting insulin at meals and long-acting, so to reproduce the natural pattern as closely as possible. Okay, which of the following are the effects of insulin on protein metabolism? Okay. Right. And Aisha says it is B, which is the right answer. So remember, through these different MCQs, we are adding to our information and to our knowledge. One of the effect of insulin is to protect or to prevent protein breakdown, and it also increases protein synthesis in the liver. All right, so B is the correct answer. Effects of insulin on protein metabolism: increased synthesis of protein, decreased protein breakdown in the liver, and increased amino acid transport into the cells. Okay, and I think we will stop here because our time is over, and we will keep going tomorrow we'll start from where we left. All right. Is there any question or comment or anything you want to add? Otherwise, we will stop here today. All right. If nothing, then there is something on the chat. All right. You are most welcome. And I will hopefully see you all tomorrow.